All right, thank you all. I'd like to thank the ASAP organization, and particularly Dr. Heger. He lost a bet, and I made him invite me here to speak. No, I'm just kidding. I lost the bet. So in usual, I put some disclosures in here. I've got no conflicts of interest, and there may be some off-label use of medications in this presentation. I'm talking about inpatient management of pain in children. I am a pediatric hospitalist at the Children's Hospital of Georgia in Augusta, Georgia. We are a freestanding hospital, 154 beds. We do have NICU, PICU, ORs, pediatric anesthesiologists, and a whole host of things. We are a tertiary and occasionally quaternary referral center. The Masters Golf Tournament is what we are most famous for, I think. And we're associated with Augusta University, which is Georgia's only public state medical school, and usually top 15 in the nation as far as size in graduating classes. These are our dolphins out front, and that's a picture of our hospital there. I am not a surgeon. I take care of kids in the hospital only. I'm a pediatrician, but you cannot make an appointment with me. I don't have a clinic outpatient. I only take care of hospitalized children. And I guess I've sort of become a Chiari hospitalist, as Dr. Heger put it, sort of by necessity. So here are some objectives. A lot of this stuff has been done adequately and perhaps better than I would do it. So I'm going to improvise a little bit, try to let you reclaim some of your time. So we'll go ahead and get started. I'm not going to post pictures of Chiari and Syringomyelia. You all have seen all sorts of excellent MRI images, cartoon images, some Frank Netter I saw, and maybe some original Dr. Gray. But so the point here with Chiari and Syringomyelia is that oftentimes these are diseases of symptom presentation, and one of the most common symptoms is pain. As a hospitalist in peds, I usually see these kids post-op after their surgeries, but occasionally as readmissions for these pain syndromes. So what is pain? We've seen definitions of pain. Everyone knows what pain is, as only a surgeon could do. We've had the idea that a presentation might relieve some of your pain from sitting. That is next level stuff. So my point here is that there are lots of types of pain. Actually, most of these I think were mentioned by Dr. Heger in this last presentation. So I won't belabor that point. But I don't think I've heard it presented here. Originally, at Cornell University in the 1940s, they tried to categorize pain based on these units called DOLS, which is maybe Spanish or Latin for dolor. It has to do with pain. And no pain is 0, and anytime you could have a perceivable change in the amount of pain, that went up by 0.5. They used a heating device which got very hot to submit or subject pain on these patients. And they unfortunately used pregnant ladies as sort of a comparison, so they could compare the heat pain versus labor pain to compare which one's worse. And some of these people did get 2nd and 3rd degree burns. And so this was clearly research now is better, but this was sort of a failed experiment, but we all want to classify what pain is. So we have different scales. This is very common in verbal children and adults is a numeric pain score. You all have seen things like this. There are also non-discrete, meaning like a continuous line like this, where you place along this timeline where your pain is, and it can help give you, you don't want to say your pain is a 4 because they won't do anything for you. You don't want to say it's a 10 because they won't believe you. So, 7, 8, 9, that seems reasonable. And something like this helps to cross some of these barriers with measuring your pain. In children who maybe are not verbal or non-mathematical, the FACES scale is common. Kids can point to a face to say how they feel, and this is another very common pediatric pain scale. Dr. Heger mentioned pain expectations. I think these are important conversations to have at all stages of this process. On your very first referral to a surgeon, talk about what pain you're in, maybe what your post-op pain expectations would be. What are your desires for pain control? I think everyone wants to achieve a pain-free life. but that may not be what is reasonable. There are multiple ways of decreasing pain. If you are at a constant 8 out of 10 pain, and we can take that to a constant 5 out of 10 or 4 out of 10, then that is improvement. If you have, 10 episodes of 10 out of 10 pain a day, and we can take that down to 2, yes, you're still having significant pain, but we have also improved your pain relief through decreasing the frequency of that pain. So these are questions that the surgery team needs to be having, the anesthesia team. If you're being cared for by a hospitalist after surgery, our hospital does. Some patients are under the surgeon's service. They're just discussions that need to be had and rehashed from time to time as well. So pain medicine, there are all types of pain relief methods, and we are going to, a lot of these have been talked about before, so I will try to rush through some of those. I think I still have some novel stuff to present in here. So we'll be talking about some of this and talking more about matching pain medicine. So regardless of your type of pain medicine in the hospital, it's important to time pain medicine delivery to your expected pain experience. So immediately post-op, you need to give pain medicine for the post-op pain. If they have a chronic underlying pain, then maybe a long-acting, slow-release pain medicine works. If it's episodic, that you're putting them through physical therapy 2 or 3 times a day, give them some pain relief either just before so that they can go participate or just after they've gone and worked out. Physical therapy is PT. Sometimes it's physical torture. Other times it's physical therapy. So if we can match pain medicine administration to expected pain experience, we can get better pain control using the same amount or less medication. A PCA, I think, has been mentioned. This is a patient-controlled administration. It's done through an IV medication. A patient gets a button. You can deliver a constant drip of pain medicine through this. It does use opioids, so we're going to try to decrease the use of a PCA. But it gives the patient some control. They've got a button that when they press it, it gives a small dose of medication, and then there's a lockout period for patient safety. But this has been, in pain literature, this is shown to be effective. It not only provides the pain relief, there's also a sense of you doing something. This is like a thermostat in a room. Even if it doesn't actually work, changing the slider sometimes makes you feel warmer or cooler. So a PCA can provide, just through a button push, this psychological relief that, someone has done something for me. That person is me. Only the patient should press the button. This is a safety issue. If you are sleeping and your respiratory drive is decreased and your parent is pushing the button for you, they can put you into respiratory failure. So in our hospital, we're very specific to parents. Only the patient pushes the button, which means that infants and children aren't eligible for that, or infant and young children aren't eligible because, you can't get a baby to push a button. IV medications, I think you all know, these are very rapid onset of action, and then they also tend to fade quickly. But this is unfortunately a very easy go-to in the perioperative period. The cons there are listed. It does require an IV, which in pediatric is a source of pain and anxiety. IV placement, IV use, looking at the IV, touching the IV. Kids do not like that little plastic catheter in their arm. And they tend to be more expensive from a hospital standpoint, so switching to POs from a bottom line is preferred. Oral medications, the pros here are basically the opposite of IVs, is that they're cheap. You don't need the IV catheter. They can be done at home, but they do require that they be absorbed from the gut. So for kids vomiting or for kids who have underlying gut motility issues or a short gut or something, oral medications, you get uncertain absorption into the bloodstream, which is where medications act, is through the bloodstream and through the brain. Other options here, rectal suppositories. They don't require you to swallow, but it can be a tough pill to swallow. And patches were mentioned. These are transdermal. Again, some question of how well the medicine's absorbed, but generally these are felt to be pretty good. And then in children who put things in their mouth, if a transdermal patch does get into an oral mucosa, your absorption goes way, way up. You can easily get overdose. So you just got to put it somewhere the kid can't reach it and have parents monitor it if it starts peeling off and stuff. So we're going to talk some briefly about the options of pain medicine. This is acetaminophen is Tylenol, in some countries called paracetamol or APAP. This is a non-opiate, non-steroid pain reliever. You don't get any anti-inflammatory effects, which can be helpful. The anti-inflammatory effects can be helpful. So Tylenol provides good pain relief, but if you have an inflammatory issue, maybe Tylenol isn't your first line. It's got a very long history of safety, including even in pregnancy, as Dr. Akula, I think, mentioned. It is extremely inexpensive. Keep in mind your max daily dose because of liver toxicity. So in pediatrics, we do milligrams per kilogram dosing. So 75 is basically 5 doses a day at 15 milligrams. That's sort of your max dose. Next is ibuprofen, Advil, or Motrin is the liquid formulation of this drug. This is another non-opiate. It has anti-inflammatory effects, which can be helpful. The studies on Tylenol and Motrin suggest that both can provide mild to moderate pain relief and that it can also be very individual. So if you have a history where Tylenol works well for you, then probably we recommend taking Tylenol. If your history has always been with Motrin and you've had good effects with it, then probably Motrin. These are both over-the-counter and reasonably safe with some caveats here in red. I am also a fake nephrologist. In addition to being a Chiari expert, I take care of all of our nephrology patients, and so our kidney doctors hate the use of ibuprofen because all he sees and they see are problems associated with it. But if you ask our nephrologist what he uses for his back pain, he says, oh, I take ibuprofen, full glass of water, drink, you know. So if they have renal abnormalities or the child is dehydrated, be careful. This is a renally excreted medicine. It dilates your efferent arterioles and can cause renal injury. And some of our surgeons, this seems to be surgeon specific. There's evidence both ways that ibuprofen and other NSAIDs can interfere with bone healing long-term, short-term, maybe not as much, and then also can represent a bleeding risk. So I always sort of defer to my surgeon's preference on NSAID usage. Personally, I do love NSAIDs for pain management. The next NSAID is not really used much in children. It's aspirin. This historically was a great pain reliever. Then there was an association that was known with Reyes syndrome, which is an encephalitis, usually with a virus like influenza, and aspirin at the same time. This is a devastating illness, so we really have stopped using aspirin, except in certain circumstances in children. Older children, probably less of an issue. There also are antiplatelet effects that we use aspirin for this very reason with low-dose aspirin. So again, kind of defer to my surgeons on that. Get the gastric mucosa, if you've got a history of ulcer diseases, I think this was mentioned yesterday as well. There are enteric-coated aspirins that make it through your stomach because of the enteric coating and then have less effect in the small intestine where they're absorbed. Toradol. This is an IV, and I guess there is an oral form available. I usually describe it as a more powerful ibuprofen. Can provide really excellent musculoskeletal pain relief, kidney stone pain and stuff too. Have had very good results with Toradol. Studies have shown after about 5 days of Toradol, you are highly increased risk of these gastric ulcers and also renal toxicity. So our hospital limits Toradol to 5 days. After that, you need to switch to other medications. Ofirmev is IV Tylenol. This is a hot topic, I guess. It's an expensive medication comparatively when you compare it to oral Tylenol and opiates. The issue with our hospital and our pharmacists is that the studies have not really shown this to be more effective than Tylenol taken by mouth or given rectally. So because of its expense and because I have a hospital pharmacy that rounds with us, that's what I do. I'm sorry, I should have mentioned, I'm not a surgeon. I round every day for like hours and hours, and this is like what I love. I've got a captive audience just like you all. It's my resident team, and they have to listen to all my jokes and sort of laugh politely, and it's wonderful. But I have a pharmacist who rounds with me, and whenever we talk about IV Tylenol, it's a fight about why can't they take oral? Why can't it be put through a G tube or an NG tube? Why can't they have it rectally? I think I'm going to use the getting away from opiates as a drive toward the IV Tylenol. Maybe start with, give us 2 doses per patient, and, I'm going to work on this because I think Dr. Chayet yesterday presented some very nice plans with IV Tylenol. Next, opiates. I am going to take a little bit of time to hate on some opiates. This is a very old standard. The opium poppy's been known about for a very long time. Morphine was named after Morpheus, the god of dreams, because it does have sort of these psychological, like euphoria feelings with opiates. They work on this mu receptor, which is a pain receptor that somehow selectively decreases your nociceptive pain without affecting things that Dr. Heer was talking about in the nervous system, like your light touch, your vibration, hot-cold sensation. And then it is currently public enemy number 1. Someone yesterday mentioned that the government regulates how much opiates are produced, and so our hospitals actually are running on shortages of some IV medications because of a national drive to limit opiate use. So 20% of deaths in this age group this year, the 25 to 34, were caused by opiates. Some of them legal, some of them, so heroin's an illegal opiate, but there are many legal opiates. All opiates do cause a physical dependence on opiates over time. We are seeing a ton of newborns being born to mothers who were either addicted or chronically prescribed opiates that have very long hospitalizations as they basically withdraw from opiates. And most addictions start with some legal prescription of medicine to the patient or someone in the patient's family that is just kept at home and not discarded. Opiates can provide extremely rapid pain relief and extremely good pain relief. They can take your pain down to a 0, which again would be, everyone would love to be pain-free, but it may not be what we should expect long term. There are many options here. There are even more than what are listed. There are genetic factors that have long been known about things like codeine, but it looks like there are other genetic factors that interfere or potentiate your relief from opiates. So basically what I'm saying is that opiates need to be individualized to maybe what a patient has had in the past, if you're opiate naive or if you've been exposed a lot. So you can't just prescribe everybody the same amount. You really need to develop that relationship and see how pain relief is going. They are rapid onset and sometimes short acting, so you get a pain level of 0, and then as the medicine wears off, all of a sudden you're right back into that same pain, and so then you need more. You say, well, it's not working anymore. I need it more frequently or something. So opiates are great in their place, but we do need to be careful. Patients, I mentioned the physical dependence, but you can also become tolerant to opiates. I mentioned the opiate naive patients should be given lower doses. Everyone with continued exposure to opiates will develop tolerance to the pain relief aspect of the medication. We do not develop the same level of tolerance to its side effects, meaning sedation, constipation. So we have to give higher and higher doses to achieve the exact same level of pain relief we were getting earlier, but we are still getting the same respiratory depression and the bowel depression that the other doses were given. So you potentiate side effects without getting the increased pain relief. There's one more reason just to be careful. There really is no maximum dose of opiates. Some of them have Tylenol, and so you got to worry about your liver toxicity. But the other thing you worry about is just putting the patient to sleep under anesthesia and causing them to stop breathing. This is how the deaths occur with the very strong opiates. The side effects we mentioned, constipation. Itching is mast cell activation. Causes nausea, causes constipation. And this, I think, again, I heard mentioned yesterday, constipation is a source of pain. It prolongs your hospitalization when it is present. And then the other side effects are sedation and euphoria. But we're going to talk some about evaluating what their pain actually is, because constipation can be caused by opiates and then can cause pain, and the way we treat it, because they're already on opiates, is to give more opiates and then more constipation. And so this can be a sort of a vicious cycle that someone has to stop and think about what's really going on. So it is okay to use opiates, but we should be careful. And then I mentioned some of them are mixed with Tylenol because there are synergistic effects. If the two are given together, they give better effects than either one alone. So that's why we have so many combination opiate medications, your Lortab, your Percocets, things like that, is for that synergistic effect. And then it's important to say, what is your pain goal? Because with enough opiates, you can get zero pain, but if we don't think your condition predisposes you to zero pain, then maybe that should not be our goal. We should have other goals. So other medicinal options. So these are like non-pain relief, but they work on those other causes of pain that Dr. Heeger mentioned that I listed a little earlier. Benzodiazepines are used for a lot of conditions, seizures, alcohol withdrawal, muscle spasms. So after surgeries are in and around the spine, we have very strong axial skeletal muscles that can spasm very hard and cause significant pain. So benzos can help with muscle relaxing, and the NSAIDs can work in that same space. Benadryl, we use this in pediatrics because of its safety for all kinds of things. The itching, trouble with sleep, anxiety. It has anti-nausea effects in children. So we use Benadryl for a lot of reasons in the Children's Hospital. Gabapentin and pregabalin, that would be Lyrica and Neurontin. I think Dr. Chayet mentioned those. They can help with the headaches that we know exist, and also neuropathic pain, which can develop or can be present prior to surgery. So one of the questions for us, because I'm a pediatrician, is what can parents do? And I think number one is be patient with us. We are humans. We have other patients. We have family at home, outside issues. So be patient with us as we try to pretend not to be human, but ultimately we are. Have realistic conversations with your care team about what our pain goals are, and what our expected outcomes are before surgery, right after surgery, in follow-up appointments. Help provide an accurate measure of your child's pain. So generally, parents do a very good job, but occasionally it makes it hard when we feel like we don't get an accurate, if you ask 0 to 10, what's your pain, and the only answer you're ever getting is 13, it's actually really hard to assess what that means when it is purposefully off the scale. Parents know their children way better than we ever will, but sometimes when what I'm hearing is, my child isn't talking to me, it's because they're in pain. They're usually very talkative, and now they're not talking to me. It's because of pain. I need pain medicine. Sometimes, yes, but other times, I've had parents say, my kid is sleeping more. I think it's because they're in pain. It's very hard to prescribe opiates to someone who is sleeping. That is bad practice. But you are the expert, so just help provide an accurate measure of your child's pain and an idea of what you think the pain is coming from. Is it the surgery, or is it constipation? Is it that IV that we haven't used in 2 days? Is having that IV in the arm the biggest source of anxiety for this kid? If it is, I'll take it out. If we're on oral medicines and their biggest complaint is that they've got an IV that's sitting there bothering them, they stare at it all day, they're in these no-nos, which are braces that go across the joint so you can't bend they're called no-nos. Help make your child's hospitalization less stressful. So bring in their toys, their games, meaning their Xbox or whatever handheld thing they have, their security blanket, whatever it is. Bring in the stuff that helps normalize the hospital. One of my residency attendings mentioned, if we put somebody on a cruise ship and confined them to their room for a week or 2 weeks, even on a cruise ship, that would not be a pleasant experience. We are doing the same thing to them in this hospital. We are saying, this is your room, you stay here for a week or 2 weeks or whatever. So the hospital is not a good place. Manage your own stress. Your children respond to your level of anxiety, your worry, the things you're saying, how you interact with maybe people on the phone because you're dealing with bill collectors or whatever. Manage and hide your own stress from your child so that they are not experiencing that stress with you. Child life services in a dedicated children's hospital, most of them will have child life services. These are folks who are specially trained and certified in child life, and this is distraction, explanation of procedures in child-friendly terms. Our child life brings stuffed animals that have, say, an IV. They'll have an NG tube, the stuffed animals. They'll show them like what that means as far as where it's going to go, and it goes into the teddy bear's stomach. And so child life has all kinds of really helpful tools for normalizing the experience in the hospital and helping speak a child's language, because this is as a pediatrician, we are trained certainly to do some of this, but maybe your surgeons are not as trained. Allow visitors to the hospital who are going to be helpful for recovery. So siblings, but if there's just some nosy neighbor, protect your child from that person. You should be allowed to sort of dictate who comes and goes. If your child needs to rest, kick people out. These are all things that and then be the expert and advocate for your child for sure. There's no one in the hospital, even the people that know your child best, who know your child like you do and have spent as much time with them as you have. What can providers do? We can be patient with parents and guardians. They have a sick child, a hospitalized child, something that most providers have not gone through. They feel this need to protect their child and to prevent suffering. And pain and suffering are two different things. You can have pain from working out that is good. You can have suffering, which is bad. Physicians, nurse practitioners, providers have a tendency to identify with what their job is. Who am I? Am I a father? Am I a carpenter? We have a tendency, I'm a doctor. A parent has the same source of identity, that they are a parent and their job is to take care of their child, to protect their child, to help their child develop. And so this is sort of their identity, and when a child is hospitalized or is in pain, they feel like they are failing. The other thing is parents get very limited time with their providers. It's not uncommon for me to have 16 patients in the hospital. If I had no other job other than to spend 8 hours a day completely with parents, that is only 30 minutes. But the reality is I have teaching responsibilities, I have new patients being admitted and other ones being discharged. There's all kinds of paperwork and meetings, and so at the very best scenario, an unrealistic scenario, parents could have 30 minutes per day with their provider, and the truth is they get much less than that. There's a plug here for academic institutions where, yes, it is sometimes annoying to have a student and a resident and nursing students, but it increases the time with providers. It increases the minds who are thinking about your child. And oftentimes some of these things we're going to talk about are sort of discovered through a medical student, not through a physician or other provider. So getting an accurate reflection of the pain and its causes. if I'm in there for 10 minutes a day, my students will come in and they'll ask the right question. It's like, so your surgery hurts. And it's like, no, it's not my surgery, it's my IV. It's, I haven't had a bowel movement in 6 days. So oftentimes there's a benefit to have someone who is learning instead of someone who is learned. Is it actual physical pain? Because we can do stuff for that. Or is it are these other things, fear, anxiety, maybe you didn't know, but their grandmother is actually in the adult ICU at the same time, and they're all worried about grandma. And so, maybe their parents are having to leave every day to go work to pay for the hospitalization and keep insurance, and they are just sitting around the hospital alone all day as a 3-year-old. This is not uncommon. So dealing with loneliness in ways can help with pain. Ask the parents and patients what they think. What do you think is causing the pain? What do you think might make your pain better? There is some reassurance that happens when you can make yourself and your clinic available. If there's a discharge plan, a parent knowing that they can get hold of somebody when they go home can just ease a lot of burden that, they're worried they're going to go home. Maybe they can't get their medicine filled because prior authorizations. So make yourself available, or your clinic, just someone to be available if there are problems or questions. And then consider non-medicinal pain relief, which we're going to talk about next. So complementary and alternative medicine, I think I've heard a little bit of this mentioned. I think Dr. Kula mentioned meditation. We have at Augusta one clinician who has a mind-body clinic 1 time a week. And this is sort of a self-hypnosis clinic. I got to rotate through when I was in residency, and there are techniques to be learned in this clinic that can help any person deal with any, if it's anxiety, if it's pain, any unpleasant experience. There are techniques with mind-body clinic that can be helpful. So he is a great asset. He wishes he could expand to more than just 1 afternoon a week, but the mind-body clinic at Augusta University is an excellent thing. Child life I mentioned, music or art therapy. We have through Child Life some of this stuff. Aromatherapy in the hospital is we allow some of that. If it gets to be overwhelming for nurses and other patients, then certainly you have to limit how much aroma you are allowed to have in your tiny hospital room. If they're having trouble breathing, we should probably cut it down. Essential oils, I feel like, are mostly without risk. I think Dr. Chayet mentioned if it doesn't make you broke, and I don't think it has much risk, then go for it. So I only know of really one good evidence-based essential oil study out of Vanderbilt, and it was really looking at essential oil as aromatherapy in a nurse's station. It was effective, but there's just not a lot of good scientific, double-blind stuff available for that. Acupuncture, there are a lot of studies about. We don't have this in the hospital. I think it's a risk thing of, if someone's poking tiny needles in you and you were to get an infection, that's on the hospital, not the acupuncturist. So outpatient, there are very good acupuncture studies. Nugget therapy, I am fairly certain this is the first therapy you all have not heard about at this conference yet, and I'm thankful that I have something. So anyone heard of nugget therapy? Because I think you could maybe bring it to an institution around you. This is Nugget. We had a grant that was given through a private donor for a facility dog. He's not a therapy dog, but Nugget is our facility dog. And he goes and visits patients with his child life caregiver, who is also pictured here. And this has actually, in certain anecdotal situations, Nugget has provided just really excellent pain relief. Also good for the employee morale. There was one time I was walking down a hospital and there was a door with a tiny little glass slit, and as I'm seeing it in the distance, I see one of our nurse practitioners like flat on the floor with somebody kneeling over her, and I thought she had coded in our clinic. So my heart rate goes up, and I rush through these doors, and there is Nugget licking her face. She's flat on the floor, and the other person's just kneeling down petting Nugget. And, so she basically just melts every time she sees Nugget. And okay, so with this is my family sort of on the left. I didn't have any new pictures, so that's 4 of my children on the left, and then my newest on the right, who some of you have met, some of you have held, I think. He's here this week. And I guess we can do questions in the panel. So thank you all.